Okay, our next speaker is Dr. Chiara. I told her I would apologize up front for mispronouncing her name, but I didn't. Bellini, who is a professor here at Northeastern in mechanical engineering.
Well, good morning, everybody, and thank you for having me. As I mentioned, my name is Chiara, and that's not the only reason why I was invited to speak today. I promise. I actually started working with Frank. I am a professor in bioengineering. I've been here for the past 10 years or so. My talk may be a little bit different from other wonderful research talk that we have or will hear today, because rather than presenting a complete study or even really collected data, I'm going to share a question that we are just beginning to explore, and so we welcome feedback. So my own research has largely focused on the cardiovascular system. This slide shows two examples of that. Up top is a finite element model of the left atrium of the heart. Sorry, I was trying to play the movie. And for the study of atrial fibrillation, and then at the bottom is a gross anatomy image of a thoracic aortic aneurysm. Is a mouse model for biomechanical phenotyping of those tissues. So, however, over the last few years or so, my colleague Frank Loth here has convinced me that some of the same approaches may help us think about a very different tissue, the dura and the myodural bridges, which Dr. Klinga has so beautifully described in her talk. And we think that they play an important role in Chiari. So therefore, today I want to share how ideas from cardiovascular research led us to think differently about the dura and the dura myo bridges in Chiari, and how we are beginning to study it. To do that, and following up on Ning-Weng's earlier remarks, I first want to introduce two concepts, which are biomechanics and mechanobiology. So biomechanics asks what forces act on a tissue and how the tissue deforms in response to those forces. And then mechanobiology asks a question, which is, what do cells do with that information? How do they sense force? How do they translate that into a biological response, which may be a change in configuration, a change in attachment, a change in gene expression, and so on and so forth. And so often that response is referred to as or brings to growth and remodeling. So that means cells adding material, removing it, reorganizing, modifying it, changing the tissue not just today, but for over months or even years. So really the question is not only what forces a tissue experiences, but how those forces might then shape what the tissue becomes over time. This idea is certainly not new, and it dates back at the very least to 1892, when Wall's law formalized that essentially bones adapt to the load that it carries. And we see these at both extremes. Astronauts lose bone during long stretches in microgravity, and then athletes on the other side gain bone mass with repeated loading during training. And so in that sense, the structure of a tissue can contain a record of its mechanical history. And that is really the idea that I would like to keep you to keep in mind today. Could the structure of the dura and of those bridges reflect the mechanical history that the tissue has experienced over time? One way to think about this process is through the concept of mechanical homeostasis, which again Ning has touched upon earlier. So just as the body regulates things like temperature or pH around a preferred range, tissue also appears to regulate aspects of their mechanical environment. And so mechanical stimuli, and you can think about pressure, flow, stretch. My postdoc advisor mentioned that cells really don't take continuum mechanics classes. So any of these stimuli, they are able to sense. And they create a local mechanical state that the cells can sense. And so the next step is cells effectively comparing that state with a preferred range, or what we call a set point. If the mechanical environment deviates from that set point, that cell responds by altering their behavior and altering their tissue around them, or both. And those changes then in turn feed back to modify the mechanical environment itself. Central arteries provide a really straightforward example of these control system. If blood flow increases, then the shear stress increases, and that increase in shear stress is sensed by endothelial cells, which make sure to produce nitric oxide. The vessel dilates, which brings the shear stress back towards its normal range. Pressure produces quite a different response. If blood pressure remains elevated, then wall stress increases. Over time, the wall then thickens, and that redistributes the loads and brings the stress back to its preferred level. But in both cases, there is the same basic concept, basic sequence. There is a mechanical perturbation that is sensed, the tissue adapts, and then that adaptation tends to reduce the original perturbation. And so this negative feedback is what is, in essence, mechanical homeostasis. However, the same remodeling process that adaptively restore homeostasis can also become self-reinforces and maladaptive. For example, sustained abnormal loading, which we had talked in the previous presentation, injury, inflammation can all contribute to shift cells' behavior from or towards excessive matrix production, which results in fibrosis and tissue stiffening, which we all know it's bad for motion. So one key regulator of this process in the vasculature is cytokine TGF-beta. But important for our story, TGF-beta has also been shown to promote collagen accumulation in fibroblasts that had been isolated from the human dura. And so that tells us that the dura is capable of active remodeling. But what actually drives that remodeling remains much less clear. Before exploring whether mechanics may be one of those drivers, then we need to ask more basic questions, or rather pulling together information that we have learned throughout the day. What forces does the dura and these bridges actually experiences? And this is where the cerebrospinal fluid or CSF comes in. So Frank taught me that CSF does not simply flow in one direction, it moves back and forth with every cardiac cycle, and we have seen it with Dr. Oshinsky's presentation this morning. So dynamic modeling of the spinal canal have shown that this pulsatile motion generate pressure gradients, generate shear stresses, and that these forces depend very strongly on local anatomy. And of course, this matters the most where the scalp meets the spine. At the center of that region is the foramen magnum, and that's the opening through which the CSF normally passes through. And in Chiari, that's the region where the tonsil descends, and that effectively decreases the space available for CSF motion. And we've seen beautiful images about that. So at this point, I hope that these two sides of the problem may begin to come together. On the fluid mechanics side, we know that altered geometry changes CSF motion, and imaging and computational modeling can allow us to quantify patient-specific CSF velocities and pressure gradients and wall shear stresses. Those are the mechanical stimuli. On the tissue side, we know that the dura is not a fixed or uniform material. The thickness and mechanical properties changes with individuals and age. And in Chiari specifically, Dura collected during the compression surgery has been reported to be substantially thicker than normal, and there are abnormalities in collagen organization, and there are even evidence of calcification and ossification. Those images that Dr. Klinger actually showed are much better than these histologies. The TN images really show the collagen disorganization. However, these two sides of the problem have largely been studied separately, and we do not know whether they're connected within the same patients. And so we do not know whether CSF fluid dynamics environment is related to the structure and mechanical behavior of the dura and myodural bridges. So this is exactly one of the questions that Hannah Higgins, that is a student in Frank's lab, she's sitting in the audience there, we're going to hear from her this afternoon, is trying to address with her PhD work. To complete this project, she has received a very prestigious and competitive fellowship from the NSF, and I'm looking forward to continue supporting her as she moves this work forward. So the work has three components. The first is the imaging and the modeling, and these obviously is Frank's and John's expertise. So let me know if I'm saying something wrong. So before decompression surgery, these patients undergo as part of the clinical care. Each patient has an anatomical MRI scans and a phase contrast MRI scans, which then again will allow us to measure CSF velocity, and then the data will be used to construct patient-specific models to quantify these forces that act on the tissue. So shear stresses, pressure gradients, flow patterns in the region of interest. So the second part is planar biaxial testing. This is kind of the bread and butter of my lab. During the compression surgery, we will collect excised samples that we have seen in the previous talk. One specimen will undergo planar biaxial mechanical testing by essentially stretching it in two axes that corresponds to the anatomical circumferential and longitudinal axis. The resulting stress and strain curve or data will be used to estimate the parameters of a constitutive model, which will allow us to predict geometry, stress, stiffness, and other mechanical metrics of interest under physiological loads. And the last part is multiphoton microscopy, which is another technique that I have, that we recently established in collaboration with another colleague, Cardiovascular Bellini, who was not able to be here today, unfortunately. So a second specimen adjacent to the first will be image using multiphoton microscopy to directly visualize collagen microstructure, revealing how collagen fibers are organized, and that will include orientation, that funny circle over there, alignment, architecture. And so for each patient, we'll be able to connect these three levels of information: fluid dynamics, mechanical behavior of their dura and the myodural bridges, as well as the collagen microstructure underlying that behavior. And then we can ask whether differences in fluid dynamics are associated with differences in microstructure and mechanics. But ultimately, again, why do we think these matter? And so, as I've been learning, Chiari is characterized largely by anatomy, and especially how far these tonsils have descended into this space. Anatomy alone may not be the only player, and so we may have people patients with the same anatomical features, but have different symptoms and different outcomes of surgery. And so we do think that dural and myocardial and myodural tissue remodeling may be a missing piece of this puzzle. Right now, it is essentially invisible to clinical decision making because we cannot assess it until we take it out and test it in the lab. And so we are at the very early stage where we ask the fundamental question: does a patient CSF fluid dynamics correlate with their dural myodural bridge structure and mechanical response? And then maybe if that's the case, this would be a first step in considering Chiari disease of maladaptive tissue remodeling as well. And on that thought, I will conclude my presentation, and I looking forward to continue for the rest of the day, and happy to answer any questions.